tech wise, and now that I said that, I've probably jinxed everything like this. We've got a microphone that will have you wear too, so we'll put on mic. I'll go grab that. I don't know if our IT guy is around, but if not, I can do it.
You were thinking probably 25 or 30 is kind of about the numbers you were thinking.
Yeah, it says anywhere between like 15 and 25. We've had, sometimes we have more people in person and more people online, and other times it's the inverse. And
Well, I just made a handout. I was talking to one of the mid-levels that works with us and she said, oh yeah, people like handouts. Give me a handout.
yeah, for sure.
Okay, all right.
Yeah, we'll put something together. That's a good idea.
By the way, hi, Jeff. Hi, Jeffy. 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 Rudy. Yeah, just let me know if I can help you. Great. So no, I'm setting it up, sorry.
And what we have done in the past for these is I will sort of not really moderate, but if people online have questions, I'll raise my hand and read those out, and if that works for you.
Perfect. Yeah.
Okay, so this should be all set up. You'll see that folks on Zoom are seeing what they should be seeing. Look. And this works somewhat counterintuitively in the down with the slide board. Okay. Let me go grab the mic. We'll make sure that's all working.
Thank you.
Oh, thank you. Hey, Heather, how are you?
Good, how are you, Bubba?
Doing great. Do you mind if I put these on this table right here? That's what
That'd be great.
most people.
Anywhere it's easiest.
When we typically have handouts, they put them there, so people
Okay.
expect them there. How are you? Yeah, I'm excited to see. Yeah. Not that we don't appreciate you. I say that next time I have like a massive, I cry.
Uh-oh.
So, hi, how are you?
Yeah. The label on the mic, number 4, is in the bottom. New straw is where we want it to end. So why else?
That's what I kind of figured. But when you were out on Friday, I couldn't quite, I didn't use it because I couldn't quite, I didn't want to risk whether I knew it or not.
Yeah.
And it worked out okay with the audio, but okay, cool. That's easy.
Yeah, that's it. It's
You said right though, like the mic and the in-ceiling mics and like them.
Yeah,
They sense from that, yeah, much.
Yeah.
Cool. Alright. Sweet.
I would say if there are like people complaining about you doing you. Like, there used to be an animal that I don't.
People, every journal club I ask, like, how's audio sounding, and everyone's always saying.
Really good.
Yeah.
Yeah, so sometimes there wants to be an echo, but that is not sweet, so.
Cool. Thanks, Ian, I appreciate it, man.
Hey, no.
But Shepard, I'm gonna have you just, you put this on, put it in your pocket, whatever you want, and then clip this on, and then just before we get going, I'll have you flip that on.
Good, how are you?
Thanks.
Well, I'm around this, when I get started and.
I mean, you're more than welcome to be all these. But, sometimes feel like with this and classroom level, I have to use too. It's fine, you know, like menial things.
Okay.
Are you from Utah originally, or are you from elsewhere?
Grew up in Ogden, South Ogden.
I grew up in Roy.
Did you?
Yeah,
Yeah, I graduated from Bonneville.
graduated from Roy.
And,
Yeah, very cool.
So, yeah, and then a little bit here and there.
Mike Jaffe.
Good to see you.
Nice to see
How
you
you
too. It's been a long time. It's good.
Yeah, it has been. So you kind of get stuck in a rut and just go.
You get kicked out of the rut, get airborne, you land somewhere.
That is true.
How did you find this career path?
I'm still doing practice. So about a year ago, well, it's probably been over a year now, but was just chatting with Alan College about something. He said, kind of getting close. You ought to consider doing this. And I kind of thought about it. I thought, yeah, maybe, kind of might be kind of interesting and that, and so as we explored it, and I think they had some other people too, but they ended up offering it to me. And so, but it's just kind of an hourly thing. And they said it kind of evolved when Alan was doing it for years.
Yeah.
He did so much work there that he said, we just feel like now it's kind of just, a few things here and there and kind of just follow along. So I still have my regular practice, and then this is just kind of a side gig.
And internal medicine, practice? Really?
Mhm.
Oh yeah. Got it.
So
Now it all makes sense.
yeah, you're PMR as well.
Mhm.
And now where are you?
I ended up in Murray
Oh, where are you
with
at?
Vikas
Okay.
interventional spine and pain.
Okay.
And then I'm doing a bunch of medical legal. That's like half of it
Yeah.
now.
Okay.
So I spent the whole day IME on my patient.
One of those.
It was kind of cool though, because now it's like, oh, now everything makes sense. Now I got a chance to read your entire 3,000 page chart.
Yeah.
Yeah,
And now how long have you been there?
year and a half.
And where were you before?
Salt Lake Clinic. Mountain Salt Lake Clinic, and I did a year at the Smart Clinic with Mike G and
Okay.
Scott Adelman.
Because I think Chi is up at Tanner now, if I'm not mistaken.
Yeah, they sold their practice, and the new owner was not good in the sandbox.
Okay. Wow. I remember when Scott was off of St. Lawrence. It's kind of,
Really?
I think when he first came out, I think he was there,
Well,
not with a group. I think he was just kind of by there for a little while before he started. But it's been a long time.
Good evening.
yeah, good evening.
I don't know what time of day it is.
Hi, I'm Shepard, Eric Wood.
Good to see you again.
I was gonna introduce you.
Thanks
Is there
for
anything that you want me to say or not say at all?
You can say whatever you want.
Well, from the brief statement.
Yeah. Yeah.
And Labor Commission guys,
Don't mind
the
money.
graduates, mail.
Oh, you're good, good, thank you.
University.
Thank you, need a drink.
I grew up on
Way up, way
Yeah.
undergraduate. I graduated from Weber State and then.
It was, and apparently, changed the name of the college.
Oh.
Weaver State College.
Right. Yeah, it was a college in the eighties. That is correct. The Weber State College in the eighties.
I graduated from USU in 85.
Okay, okay. So I was 86. And then medical school in San Antonio. And then was at LDS Hospital for my internship.
Oh, that's kind of cool.
And then back to the clinic for 3 years.
Not anymore, do they?
Well, you know, it was kind of interesting because TM&R, you kind of had a choice and you'd either go a 4-year all-in-one or you do a transitional and then a 3. And so I think that's what. Do transition.
You over there?
I was at LDS back when that was the flag.
Yeah, yeah, I remember. It's
Yeah.
a Good part of my med school years.
Yeah.
And it was. Awesome. Except for when you get to have part of the moon.
Yeah, back then that was.
Busy time. Goes around there forever.
The Belknap and.
Yeah.
Worry about tests.
Jeff Anderson.
Bet you like that part.
LaFay and so, yeah, we did all that. I did a sports rotation.
How was your, was it 4, 5?
Yeah.
So it was my third year. So yeah, it's going really well. Very busy.
Yeah, I was there.
I gotta study, I just got my results back.
So, yeah.
However.
You joke.
Can I tell you, I have to show you, because you're gonna really laugh.
We should be good, hopefully.
So last year, when I got the results back, it was like very like, kind of like evenly bad.
Sent to.
Mention to folks that I will email everyone
Then this year,
a link to
I
the
need to
page on
look
the
at two
website
of
where
the
they can find
percentage
instructions
that
and
I
do all that stuff.
fell into this year.
How you doing?
Ian set us up.
Yep, I think we're all good up there. We're good on the Zoom. You got a microphone.
Fifth percentile.
I think we're good.
These two things, which I'm like, I don't even know what that is.
Services administration.
Is that the questions about like, who or?
Yeah.
I haven't seen anything since the.
My last year was.
Not far.
Yeah, for the, but what even are the chronic diseases?
I think so.
Because we see all this.
Talking about one bill.
Yeah, I know that. I was like, fifth percent, because last year was way higher, like.
Yeah, it was the. So I think.
Live in the dream, be in the dream. Yeah, look,
But.
last year. How do I go from, did I dump all information or did I just guess worse?
All of mine were first category.
If you had that knowledge, just mine were, do we know what like pathing is?
They wrote it in that, like the other attachment. I mean, it's like this long explanation that
Was it the 50? What did they say?
they
it was?
try to make it easy. I don't know.
Yeah, I knew that, yeah.
I was like, I don't
You
know how to interpret these things. All I know is I really need to.
know.
How can you go, how can you go from like 50% correct to? I was like,
Smart. So this thing is for this IMP. Is that a task that they reference in the?
I'll move my stuff
Oh my
down.
God.
Closer to the front.
Gotta get in throwing distance, right?
Yeah, exactly. Right.
In the little library, a little thing.
How's it going, Sarah?
Well,
my LCOs did not change.
it's okay.
Hello, I saw you ended up here.
I did have them.
I did do that.
It's good.
You were here, that's.
Was that good?
I mean,
I don't remember. I don't remember reading it before, but
I didn't LCO.
some
Yeah.
clinic, some teaching.
Really?
Some research.
like it's like
So,
in here a couple times.
clinic, 2 days a week here.
Okay.
Almost always with a resident. These two right here are residents, there are senior residents.
Uh-huh.
And then do a little bit of admin stuff. They're working on some research
That's
with
what
Dr.
this is
Yoon
about.
here.
Uh-huh.
She and I went to residence together. This is Sarong Yoon.
It's not about email.
Doug and I,
Billy, you're good, you're good.
Doug and I were just down the street from each other, right? When I was at Workman in Layton.
Mhm.
Doug was, what, not even a mile away.
Yeah.
And it was great. He
24 hours.
helped us manage all of our back and neck pain that we were struggling with.
Yeah.
It was just a great resource
I've read that
from that area.
So what was the, I mean, was it just time to change or? What kind of pulled you down?
I love clinic and I love full-time clinic, but I felt like I was not challenged enough a lot of times.
Okay.
And
So say anything about
taking residents
how
at Workman.
early you have to request vacation time?
There was a
in advance?
position here and.
It does.
Trained here.
Okay.
Gotta say, man.
I think it does.
Falcons are in the driver's seat. There's a lot of people.
It's not like I can't walk around there.
No, I just.
Their own development.
I just like panic on the agenda, like,
Yeah,
no.
I mean, there's something
See if
that.
anyone's already shown up.
Fifth round rookie Spencer.
Like, okay, it's me.
How long
maybe
is what
it's
this
just
thing
a-
about?
And then I-
Jericho.
Yeah, so he's been out for.
Thought he was shot.
No, he's on IR.
One of the things it's like.
I already need someone to leave some minimum, if not, if he.
Just found out today that we put them all out. Someone's been copied on a primary end. I usually like to email the attending committee, like, there won't be a resident there,
A
so
lot of that.
whoever is on Monday.
Roy's on.
Yeah.
Glad you came. Thank you for coming.
Glad to be here.
Yeah. Otherwise they would have told you like, well, then Troy will cover.
Yeah.
With this new guy or
So that
something,
you could call, like,
and you're talking,
Stuff right, okay.
Yeah, like the Cowboys.
Hello.
Then Mike goes in and-
How was your spring break?
I mean, small struggled with like not some great team. They needed way harder than they should have.
just go through it and do the trainings. I know I thought.
We're gonna get a handout that was available at the front. Anybody want one? Go ahead and,
So it's not like, you know, so it's not really. a big- Maybe, you know. Yeah,
He was,
yeah, just something like that. We get, you know.
You might
Oh, I have one there. Thank you.
So that residents and other people that need to-
Matt, what are you on this week?
I'm on WCF.
Oh, how is
So this one, they just wanted me to kind of go over what's
it?
new.
You schedule it, then you'll have.
Yeah, yeah, this will be the highlight, so. Or the low lights, I guess, depends on how you look.
I think it'd be high.
Anyway,
It's funny.
good to see you.
Good to see you.
You know how he has
Can
a
I go ahead and
calendar?
start it?
Yeah.
He uses the same one. Mine was on my computer, or mine was
You
on
mic'd up
my
already?
salt. Like meeting.
I'll go ahead and introduce just by voice instead of the speaker. Anyhow, it's my privilege. I'm Eric Wood. I direct the occupational medicine program here for those who don't know me. It's my privilege today for our Grand Round series to introduce Dr. Douglas Shepard. He is the medical director for the Industrial Accidents Division of the Utah Labor Commission since, I guess, 2023. And he's been doing and revitalizing at its most recent research. Dr. Shepard's a physical medicine rehabilitation specialist by training. It's a residency training at University of Texas Health Science. And as a native Ogden, he did his undergraduate work at Weber State College. Dr. Shepard, do I bring that?
Thank you. All right, it's been a while since I presented in this fashion. So we had talked about a little bit of a topic and thought the best thing to talk about would be the 2024 guides that just have come out from the Labor Commission. The prior guides actually have been in place since 2006. So, and Dr. College, who was the prior medical director, was instrumental in doing those. And he and I have known each other since I came into practice after my residency a long time ago. And so they had done a lot of the work. I kind of came in on the tail end, but he just had done some of that. So today's focus will be for those who are already familiar doing ratings. We're going to just focus really on the new stuff that's in the 2024 guides and go into a little bit more detail on a couple of sections. So I've just kind of prepared kind of a bullet point sheet for you. And I just thought, I'll throw in a few slides. Sometimes throwing up things from the guides is just not the most exciting. But I thought we'd start off. This is a picture of sunrise on the Wasatch, so we'll get started. I didn't even know. So I've been the medical director for the Labor Commission for about a year. And when I was named the medical director, I didn't really realize, but there's actually two directors. There's one that's over adjudication and then one that's over industrial accidents. And so that's where I sit. I was trying to come up with a good title, something a little bit catchy to get your attention. So I thought, well, maybe operation. But sometimes you just got to ask the hard questions. All right, now go back to eating. We're good. We're good. Okay, so first we'll just kind of take a step back and look at this thing from kind of the big picture. This is actually a view of Greenland from about 36,000 feet. All right, so first, some of the definitions of impairment. And so there's a variety of them. So we'll see if any of them these really stick and resonate with you. So it's an alteration of an individual's health status assessed by medical means. According to another one, a medical assessment of a patient's physical or anatomical deficit or loss of use of function represented by a percentage value for each deficit or functional loss expressed in terms of the whole person. An alteration of an individual's health status, a deviation from normal in a body part or organ system and its functioning. That's the 5th edition of the AMA guides. Any loss or abnormality of psychological or physiological anatomical structure or function from the World Health Organization or from Social Security, an impairment that results from anatomical, physiological, or psychological abnormalities that can be shown by medically acceptable clinical and laboratory diagnostic techniques. Clear as mud. So to kind of an oversimplification, when I have people come to me, injured workers that come for an impairment rating, I will spend a little bit of time and try to explain why they're there. A lot of times I don't know when they get there. I said, "Do you know why you're here?" Well, insurance said I had to come. Well, they're trying to close out my claim. Oh, or they're really pretty limited. And so my overboiled or oversimplified definition is it's a permanent loss or a measurable loss of a body part that should result in a permanent loss of function is kind of how I'll lean into it. And then we'll talk about the difference between impairment and disability, and then we kind of get on from there. So, all right. So the first question is, okay, how do we access the new guides? So these are all published. These are online. So if you go to the Utah Labor Commission guide or to the Utah Labor Commission website, and then first go to the left-hand side on here to the Industrial Accidents Division, click on that. It'll take you to the medical provider side. And then once you go from there, it'll take you to this one. And then you can upload it there. So the 2024 guides, actually, it's about 105 pages. The vast majority of it is already been in place since 2006. There's just a few sections that are updated and different. Dr. College over the years has done such an excellent job of explaining the history of impairment, the history of workers' comp, what the different disabilities are and kind of some of these definitions and things like that. So that's all there. So don't be overly surprised when you get to it and it's a 105-page document. Okay, that's why. Okay, so this was last fall up at, I think this was North Fork. So if any of you like to bike ride North Fork, just up in Eden, Utah, kind of Ogden Valley, Dr. Ellsworth maybe had been there. So, all right. We'll try to fill in a few things just to keep you interested. So now one of the things that's kind of important that I was surprised that came up, if you're doing impairment ratings and you're concerned about the billing, so how this works, there's two codes, 99455, if you're the treating physician and you're providing the impairment rating, or 99456, if it's a patient that is not yours, you're not treating them, and they're sent to you just for the purpose of impairment rating. And that code is for each 30-minute segment that you're with the patient or reviewing the charts and things like that. So be sure and document the time that you spend. I had one yesterday, 3 inches of records, thrown from a horse, 10 minutes of loss of consciousness, Also, it was billed as a head injury, but then they got to me and, oh, by the way, they had a wrist fracture, intra-articular radial fracture, had a pelvis fracture, sacral fractures. And so it suddenly starts to balloon out. So make sure you bill for the time. And there are times when these are not being reimbursed. So we're working on that from the Labor Commission side. So just make sure that as you do it, this is per 30-minute unit, okay? So how that's done, there's a conversion factor. Currently, if I'm not mistaken, it's $58. So you look at the RVU. So if you're the non-treating provider, 2.65 times 58 would be what you expected, the bare minimum to get for a 30-minute slot. So if these are taking 2 or 3 30-minute slots, then it should be double or triple that, okay? All right, so that one kind of important. All right, now, anybody know the breed?
Boxer?
Almost. What's that?
Boxer?
No, it's actually a frug. It's a French bulldog pug mix. So this is Mac. Okay, this is our 1.5-year-old frug, and he is awesome. Very, very friendly. I thought I'd throw him in just because he's looking around ready to go. So, okay. So now some of these things are pretty subtle as far as what's new in the guides, and the rest of the time we're really going to just focus on changes from 2006. So if you're used to the 2006 guides, we're just focusing on what's different, okay? So first thing, there was a definition of what was medical stability, and in the old guide that said, as you can see here at the bottom, the condition of the worker is not expected to change by more than 3% in the next year. Okay, that's just been removed. So it's no fundamental changes anticipated within the upcoming year. Definition of stability. So not a huge change, but that's that. All right. So next thing, this is a little bit more. So all impairment ratings are now combined. So in the 2006 guides, if you had a PIP joint that lost extension and flexion, those impairments, according to the 5th edition, are added. But when it's a PIP or in a DIP joint, those are combined. If it's a thumb, all of those are added. So it kind of gets a little bit confusing now, which is it? So, and I put over here to the right-hand side what the 2006 guides used to say, just for those that, as you're looking through, you're trying to figure now what was what. So all of them are now combined. Okay, even if you're using tables from the 2006 guides or from the 5th edition, and it's still combined. Okay, so thumb, different for each of the digits of the hand, now combined. If it's different things with the spine, they're combined. So just know it's kind of moving to the all combined section. Okay. Yeah, it should be easier, a little bit more straightforward. Now this one, again, kind of just a little bit more esoteric. Schedule 1 for non-surgical spine conditions. The schedules are the same. It's just if you look back, and I had to go back and look because it's like, I didn't even know this was there. So you look at the bottom of Schedule 1 and there's this little footnote that says, okay, these are for non-surgically treated spine conditions. Okay, makes sense. And then it goes through and gives you a little bit of a definition between minor, moderate, and severe mechanisms of injury. And apparently there was a little bit of concern from a legal kickback stage of saying that maybe that should not be included because that's more of a judicial decision and things like that. So the verbiage has been removed from the bottom. In the schedule itself, it's still the same. Okay, so it's a mild, moderate, severe injury, and then the same things that still applied. So the spine schedules themselves are the same, not changed at all. Okay. Okay, next one. All right. Any guess where this came from?
Grand Canyon.
Antelope Island. Okay. So you'll see why I threw this in a second, but a couple of years ago, my wife and I found out that there are scorpions on Antelope Island. Okay. So the idea is they come out in the summer, got to be hot. So you go out after dark with your black light. And we went out by Buffalo Grill, if you've been out there, and just kind of walked through the ground looking around. Now, to be honest, what it looks like somebody went to Dollar and bought a bunch of little glow-in-the-dark strips and cut them up and just kind of scattered them around a little bit. You may go out there and not see any, or you might go out and see 20 or 30. So the cool thing about this was taken by one of my sons with a macro lens. These are actually about the size of your thumbnail, about the size of a bumblebee, or not even a bumblebee, a little bit smaller than that. So you can get pretty close to them. And so this was done with the macro lens. Okay, now I threw this in for a specific reason. it reminded me of our next topic, complex renal pain syndrome. So, all right. Now, interestingly enough, those of you who do ratings, have you seen cases where people qualified for an impairment based on the 5th edition? I don't know that I ever did. Okay, so the 5th edition, in order to qualify for an impairment rating using the 5th edition, you had to have at least 8 or more of these things right up here. So vasomotor changes, so skin color changes, you had to have edema, temperature change, either trouble with pseudomotor changes, trophic changes, skin texture, atrophy, joint stiffness, nail changes, hair growth changes, and then you'd have to have either like focal osteoporosis, bone scan was thrown in with the 5th edition. And if you had more than 8 of these, then you could rate them. And according to the 5th edition, what you would do is you would use the amputation value of the limb. So if it's an upper extremity, 60%. If it's a lower extremity, you'd use 40%, and then you would multiply that by the severity of the sensory problems that they were experiencing. Okay, so in the 2024 guides, how we're going to do this differently now. So instead of using criteria from the 5th edition, we're going to go to the Budapest criteria, or the International Association for the Study of Pain. Similar, you'll see that, a little bit easier to get to, but you'll see that, okay? So you'll do the same thing. You grade the severity based on sensory deficit. I'll show you the tables that are included in the guides. And then you multiply that by the amputation value of the affected part of the body. Not the whole arm, it's just whatever part is affected. Otherwise, I think it makes it a little bit, it kind of reflects more the accurate involvement level. And then anything besides that, range of motion loss, you'll combine with that. Again, we're combining. If they don't meet the criteria for CRPS according to the Budapest criteria, then you can use it range of motion. If you have to, you use these painful organic syndrome ones. But as you're familiar with those, the ratings on those are not that high. I mean, it's a 6% upper extremity or 6% lower extremity are kind of the maximum values for painful organic.
Those are standalone, right?
Yes, those are standalone.
You don't
Yep.
pain
Correct.
plus range of motion.
Correct. Correct. So usually what you would do is whichever gives you the higher rating, go with that. Okay. All right. So Budapest criteria. Now this is one that I went into a little bit more in the handout because they have not included the Budapest criteria specifically in the new guides. So you have your own little cheat sheet. Okay. Okay. So continuing pain disproportionate to the inciting event. Okay, makes sense. Then you have to have at least one symptom from each of the following. So this is symptom first. Hyperesthesia, allodynia. Okay, vasomotor, so either temperature, skin color, temperature modeling, things like that. Pseudomotor changes, either sweating asymmetry side to side, and then motor or trophic changes. So that can be decreased motion, stiffness, tremor, kind of functional weakness because of the hypersensitivity, and then trophic changes to hair, nail, or skin. Okay, so at least one in each of those. And then when you're examining them, you have to have at least one in 2 or more of the following. Again, same categories, but clinical findings now instead of subjective symptom report. So if they have allodynia or hyperesthesia, hypersensitivity with light touch kind of thing. So that's one. Vasomotor, so temperature asymmetry. So what I've done, I kind of cheat because I do EMGs as well. So years ago, I bought a little spool that has like these little temperature probes that you just peel off and stick on. So that's what I use. And it's quick, it's easy, and it gives you a quick reading as to temperature from limb to limb. Okay, so that's easy. Pseudomotor, so if they've got evidence of edema, sweating changes, motor trophic changes, decreased range of motion, functional motor weakness, and then trophic changes either to skin, hair, nails. So again, symptoms from each of the 4 areas, clinical findings from at least 2 of the areas, and then no other diagnosis that can account for it. That's the Budapest criteria, okay? All right, so then this is included in the guides. This is kind of a sensory table. It's also used for peripheral nerve injuries and things like that. So if you can kind of see, so the different categories are, I'm going to have to come up here and look because I can see it better up there. Okay, so diminished light touch, kind of forgotten during activity, up to a 20% severity index. 40%, it interferes with activity, but they still have protective sensation. 60%, or grade 2 here, you can see, so decreased protective sensation, and then pain that prevents some activity. 80%, deep pain present, but no protective sensation whatsoever. And then total anesthesia would be 100%, which, so that's the same table that's used for peripheral nerve injury. So that's why you have some crossover there. Okay. And you'll see how this goes with an example here. Okay. So example, we have a 33-year-old female, motor vehicle accident a year earlier, broadsided by a 1-ton pickup truck. No fractures, but significant soft tissue trauma initially. Over the course of a year, hand and wrist continued to give her hypersensitivity distal to the wrist. Okay. In addition, marked loss of motion. She had a cooler, swollen, mottled hand, nail changes, thin, hairless, non-elastic skin. X-rays showed some focal osteoporosis or osteopenia, and she was declared medically stable, given a diagnosis of type 1 CRPS. Okay, physical examination, findings are consistent and doesn't really meet criteria for somatoform, malingering, or anything else. Okay, so how do we go to rating? So first of all, the amputation table, it's wrist distally. So if someone had an amputation at the wrist, 92% upper extremity impairment. Okay, so that would be the maximum value. Okay, in this case, it was decided that the level of sensory deficit was 40%. Okay, so grade 3 or 4. So pain enough to interfere with some activities, but still had protective sensation. Okay, so you'd multiply the 40% severity by the 92% amputation value, and that gives you 36%. Okay, now, Dr. College had included with that, then combined with 18% for loss of motion, which is a little bit of a misnomer because we don't have any of the documentation to say where'd that come from. Okay, and I think he threw some of these in. He liked to do that because he's trying to help you see through the process. If the range of motion equals 18% rating, then you combine it and you're going to end up with a 29% whole person or a 48% upper extremity impairment. That seems like a big rating, but kind of to illustrate the process. Okay. All right. Next.
Sorry, to go back.
Oh, go ahead.
If you technically had an amputation, you would have a range of motion loss anyways.
Well, if you had an amputation, then it would have been a 92% impairment rating of the upper extremity because it's gone. Okay. Yeah.
How do you decide which sensory to use?
A little bit to your judgment. Okay. So I kind of think so those heavier ones, when they start to lose protective sensation, that's when I get into those. And I think that's why this one was chosen. It was because it was kind of below that, but the patient still had protective sensations. You're not going to burn her hand on a stove and not know it. But she was having enough allodynia or hypersensitivity that it interfered with activities.
Okay.
Okay. That's kind of how I would look at that. Okay. All right. Let's go to upper extremities. Okay. And see how we're hanging on there. So this is actually my youngest son, canyoneering in southern Utah. Okay. All right. Now, upper extremity, a little bit more straightforward. Sorry, this slide's really busy, but it will make sense for those. So on the right-hand side is the 2006 Schedule 7. Okay. On the left-hand side is the new 2024. And I've highlighted just the ones that are different. Okay. So again, just to remind you, so Schedule 7, these are kind of a diagnosis-based component. And any impairment that you use from Schedule 7 would be combined with any impairment that you have from range of motion loss. The caveats, as you can see up in the dark gray here, you need to wait for at least 6 months is usually what they want. And then combined with range of motion, not to exceed 18% upper extremity. So 18% upper extremity, 11% whole person is the maximum you should have in the absence of a joint arthroplasty. Okay, so the ones that are highlighted. So the first category, bursitis, impingement, those are the same as in the 2006 guide. So you have a 2 or a 3 or a 5% based on the findings, surgery or not, and overall outcome. Okay, now where I had problems with the old Schedule 7 is it had, if you have a partial or a full thickness rotator cuff tear and it's treated non-surgically, you had a 3% or, whatever. And that would be combined with whatever you had for range of motion. Or there was another category that said if it was treated surgically and you had severe limitations, then it would be 6%. Okay, well, what if they had surgery and they say, I'm doing pretty good, but we really didn't have a category for that. So the new guides, two things really have changed. So now rotator cuff and slap lesions are both into this category, okay? And as you can read through there, there's 3, 4, and 6% categories, but they're all whether it's treated surgically or non-surgically. Okay, so whether it's a surgical or non-surgical rotator cuff tear, if they have minimal residual symptoms or limitations, it'll be 3% combined with range of motion loss. If it's moderate, 4% combined with range of motion, or if they're pretty significantly limited, 6% combined with any range of motion, again, with a maximum of 18% upper extremity, okay? All right, so I think that helps. It gives us a little bit more of an option rather than trying to be arbitrary, okay? Next, global tears to the same, a couple of new sections at the bottom. AC joint separations, okay? So those were really not covered in prior editions. So if someone has grade 1, then there's no impairment for that, but grade 2, 2%, grade 3, more significant findings, 3%. And then sternoclavicular joint dysfunction, surgical or non-surgical, it's a 4% upper extremity combined. And I don't know that I've ever seen a sternoclavicular that really went through that, but okay. And then the last one, biceps tendon ruptures or releases. So one of the things that I kind of struggled with, somebody come in, they'd have a distal biceps tendon rupture, treated surgically, and the Utah guides typically will say that you're not supposed to rate for weakness in the absence of a documented peripheral nerve injury on EMG, okay? These guys all pretty much have great range of motion, but the only thing I could find is they had a little bit of supination weakness. And I think I've seen one case in my 30 years where somebody had a distal biceps repair that didn't have a little bit of supination weakness. So I would kind of cheat and say, okay, well, there is a section that if there's a weakness in supination that's grade 4, it could be like a 1 to 4% upper extremity impairment, depending on the weakness. So apparently that's not supposed to be done. So now we've got this instead. So a distal biceps rupture, treated surgically, 4%, and then combined with any range of motion there. Okay, so a couple of new categories. I think it maybe just clarifies and gives us a little bit more options.
Tear, is that like massive rotator cuff tear?
Massive rotator cuff tear, or that's just irreparable. Okay, so I think that's the key right there. So an irreparable tear, if they're doing transfers or scaffolding, things like that. So irreparable. Okay, and again, those are probably going to get close to the 18% very quickly with range of motion loss, you'd assume. Okay. Okay. All right, next story. How many of you saw the aurora back in May? Okay, so one. So we heard about it. Okay. So my wife and I, not that we spent a lot of time on an antelope, but we went out to Antelope Island on Friday night and spent with, I don't know, 500 other people driving around and hiking around trying to see stuff.
Yes, did you get?
None. No, so it depends on what time of year you're there. So by then, it's the no-see-ums and stuff that you'll get there. So anyway, so we're out there wandering around. We saw nothing. You could see the light in the distance over Davis County and stuff. And I thought, oh, what a bust. So we stayed for a while and said, fine, we're going home. Now, my son, I mentioned that the one that was doing the canyoneering, he's actually just in his second year of medical school at Oakland University, just outside of Detroit. So about the same time, he's driving into the woods, taking pictures of these awesome auroras. Dad, you got to go do this. This is awesome. And so he kind of inspired me on the Saturday, the next day. I thought, I got to go check it out. So I drove up past Brigham City out towards the bird refuge out there. Now, the other thing I learned is you need to use your phone and take night pictures. So this is my phone, night pictures. Great, I saw the aurora, okay? Now, I kind of was questioning, is it really me or is it just some weird setting on my phone? So after 30 or 40 minutes, I tried some other pictures and there was no aurora. So you can actually see it that way. Now, why did I throw this one in there? traumatic brain injury. So the idea with trying to rate traumatic brain injuries, mild traumatic brain injuries are really hard to put a finger on. Sometimes it's hard to get a look or some way to put something to it. How do you measure that? How do you really see that? Is it there? Is it not? Or is it is it somebody just trying to make stuff up? Okay. So that's kind of where we come from. So I threw in a couple of sections. These are from the 5th edition of the AMA guides. Okay. So one of the ways to do that Dr. College had referenced in this chapter. So class 1, so mild traumatic brain injury, patient's got residual symptoms. So one of the ways you could do that is go to this class 1 and say, okay, I think there is some brief, repetitive, or persistent state of consciousness alteration. And maybe some impairment in their ADLs. What do I rate them? Oh, 0 to 14. Okay, what's 5? What's 7? Do I give everybody 14? You can see where that's a problem, okay? Another section that I came across, all right, so here's one, also the 5th edition. Now, this is an impairment in mental status that seems to me to be a little bit more for traumatic brain injury, right? Okay, well, look at class 1. Oh, yeah, 1 to 14%. Not much better. Okay, but now it references what is this CDR or the clinical dementia score or clinical dementia rating. So it looks at several different parameters. So memory, orientation, judgment, community affairs, home and hobbies, and then personal care. And so you can kind of go through and try to do it for those. And then if they have one of those, so for example, if there's some forgetfulness, a little bit of impairment, you kind of fit to which category kind of qualifies the best. And then you go back to, okay, that's class 1, 1 to 14. Great, right? So my thing was, I used to just say, okay, well, I want something that's objective that says, yes, there's some legitimate stuff here. It's not just somebody that's depressed or anxious. How do we get there? So that's kind of where I was. Now, I threw this in not to make fun of it, but just to make sure that you're still awake. So, all right. So here's, and this is kind of interesting. I'm going to take a little bit more time with this one because this is probably the biggest change that comes out with the 2024 guides. If you understand this and the logic behind it, it will make so much more sense as you're dealing with any TBI patients or mild TBI patients, okay? So, and it was kind of interesting because as I talked to Dr. College, as we were kind of going through some of the transition, he was just so excited about this. He said, finally, here's an article that brings consensus. Now, the consensus is on mild traumatic brain injury diagnostic criteria, okay? Well, that's not impairment, that's diagnosis, but it's something, it's a start, okay? So, and you'll see how this kind of evolves in just a minute. So first of all, the overview of that study from the American College of Rehabilitation Medicine, it was using 49 TBI experts, another 68 individuals, 23 associations or groups, that all organizations that had feedback, like I think the NFL, military, a lot of different, kind of trying to come across a group of different groups and a wider population base to focus on what are the diagnostic criteria to say that somebody has sustained a mild traumatic brain injury, okay? So, and then that process is going to be kind of molded and morphed and adapted to help us do impairment ratings for mild traumatic brain injuries, okay? So I'm just going to highlight from the article, and again, that's why we're going into a little bit more depth, is to give you that perspective. So according to this group from ACRM, first you had to have an appropriate mechanism of injury, okay? Some type of mechanical transfer of energy. So either the head was struck by an object, the head struck an object, so a fall, acceleration, deceleration, or a blast or explosion, okay? So an appropriate mechanism, okay? Clinical signs, some of those would include loss of consciousness immediately following, alteration of mental status immediately following, so slow response, behavioral changes, unable to follow commands, disorientation, amnesia for events right after the accident, Or if they're unable to communicate or they're intubated or something like that, retrograde amnesia can be used as a substitute. And then other motor coordination upon standing or more severe seizure, tonic posturing, things like that. So those are some of the clinical signs. And again, you'll see that these are initially right after the trauma. So as you're doing an impairment rating 6 months or a year later, you're looking for the records for some of this stuff. Okay, next, acute symptoms. And for their diagnostic criteria, you need to have at least 2 acute symptoms. Okay, so confusion, orientation problems, dazed, physical symptoms, headache, nausea, dizziness, balance issues, vision changes, photophobia, hyperacusis, things like that. Cognitive symptoms, kind of mental fog, concentration problems, memory loss, and then emotional symptoms as well, lability or irritability. So at least 2 of those, okay? All right, next, clinical exam or lab findings. And I thought this was interesting, and I'll explain that in a minute. So is there on clinical examination, are there findings of cognitive impairment, balance impairment, oculomotor impairment? And then they threw in this category blood biomarker elevation, okay? Now, interestingly enough, they specifically stated in this article that they didn't really want to specifically name anything because they didn't want it to become obsolete as more data and more studies came out. But there was reference to this glial fibrillary acidic protein, that there was a couple of references that maybe mentioned it. But just they wanted to put a little place marker there to say that as we evolve or as we gain more information, if there are biomarkers, that would be an appropriate place to consider those. Okay? All right, and then neuroimaging. Now, it's not necessary to have neuroimaging or have neuroimaging abnormalities to qualify for a diagnosis of mild TBI, but that's just another factor to consider. Okay. All right, so then the other thing, and I think this we can use as we're looking back at now the impairment rating process later, not better accounted for by other confounding factors. So initially, if their slurred speech is because they were intoxicated, hard to say it was TBI. If they have acute musculoskeletal trauma, you can't really tell if they can stand or balance. Psychological trauma, pre-existing or co-occurring health conditions, or symptom aggravation or exaggeration, sorry. Okay, so that's kind of where the criteria goes. Now, their criteria came down to, so mild traumatic brain injury is diagnosed when you have a biomechanically plausible mechanism of injury, 1 or more clinical signs, at least 2 acute symptoms, and or neuroimaging evidence of TBI, okay? And then not confounding factors that could account for the symptoms otherwise. And then they threw in on the bottom, if you have either a loss of consciousness more than 30 minutes, initial Glasgow Coma score less than 13, or post-traumatic amnesia greater than 24 hours, then that shouldn't be considered a mild TBI, okay? So that was their criteria, that was their focus. Now, that's a little bit different as it pertains to impairment, because somebody could have a more severe initial injury, but now 6 months or a year later, their residual symptoms may place them more into that mild category. So that's you can do that, okay? So here's kind of the key for how traumatic brain injury is now going to be done with the 2024 guides. So first, Schedule 12, which is what this big chapter is, or this table you'll see, it's to clarify only class 1 impairment, so that mild TBI section. If somebody's had a severe traumatic brain injury, paralysis, extended, intubation and things like that, clearly they're not going to fit here, okay? So for those, you'd go back to the 5th edition, go to the more advanced levels. Then it should be you should wait at least 6 months for rating, because so many will improve usually within 3 months. Okay, and then the last thing, if the primary concern is kind of post-concussional headaches, he wanted to include that you can use either a non-surgical spine condition, either category 1B or 1C, if it's all cervicogenic headaches. Usually there's not really a rating for headaches, but if you're going to rate it according to how it fits with the next symptoms, don't rate it in both, okay? Now, if you're using for mild traumatic brain, you'll see where the headaches come in just a minute. Okay, so the table is really big and onerous, but if you understand the background, it'll break down pretty quickly. You'll see that, okay? So hopefully this will make a little bit more sense. Okay, now I just tried to highlight and unbusy it a little bit So just remember, so we have severities, you have grade 1, grade 2, grade 3, and grade 4, and the numbers assigned 0, 5, 9, and 14. That carries through the whole table, okay? And you'll see how that plays out. Okay, so the first one, mechanism of injury, okay? And I'm going to come over here just to be a little bit different for a minute. Okay, so mechanism of injury, relatively minor. So that's minimal motor vehicle accident, bumped or contused, but nothing really more than that, okay? Severity 2, okay, slip and fall, hit their head on the wall, a little bit of a bump, but doing okay. Grade 3, cyclist, thrown off their bike, hitting their head on the pavement, short loss of consciousness. Says a CT reveals a minor concussion. I'm not sure why that was included in there, but no significant findings on CT, okay? And then severity 4, significant fall from heights, extended loss of consciousness, skull fractures, and intracranial bleeding, okay? So that'll kind of give you those categories, okay? All right, so then let's go to the next one here. Oh, good, I can't stay over here. So acute clinical stuff, okay? So if their initial Glasgow coma score, 15, next category 13 or 14, 12 would be that category 3, 11 or less, severe, okay? Loss of consciousness duration, and that's pretty quick, okay? So 15 minutes or more is already grade severity 4. All right, alteration of medical status, so the mental status initially, so responsiveness, agitated, disoriented, okay, amnesia for events, and again, up to more than 24 hours post-traumatic amnesia, considered severe. 12 to 24 is grade 3. Okay, so acute neurologic signs, we talked about those, motor incoordination, more significant, or seizure, tonic posturing. Okay, acute physical symptoms, headache, nausea, dizziness, balance problems, light sensitivity, and then clinical or imaging findings, and you can see how those kind of play out as well, okay? All right, again, hopefully you can kind of see now a little bit of the reflection back to the other ACRM article, okay? All right, so now this is the section that looks at, okay, where are they now? So chronic symptoms, headaches. How often do they have headaches? A couple of times a week, every day, never stops, every day, but can't function because of it. That's how you stratify it out, okay? Emotional symptoms, if they have any lability, irritability still, are they taking medications? Are they taking daily preventative and breakthrough? And what's the overall impact on activity? Now, and this was one of the things that was kind of the question. They talk about, okay, well, so many post-concussive symptoms are supposed to improve initially. So what happens when somebody is in a workers' comp setting and there's obvious secondary gain and they want to make it as bad as they can? Okay, so the genius of this, which doesn't make sense at first, but ends up if you really think about it, this is one category. Okay, headaches, emotional lability, there's 2 categories. You have a total of 13, 14 categories that you're going to grade. So if their initial mechanism of injury was really not much, they really didn't have any kind of loss of consciousness, no documentation that their Glasgow coma score was really reduced. Okay, the initial trauma to the body wasn't that great. So that's going to weigh it down. So they still have their symptoms. Okay, now the other thing that you could do, if you're convinced this is the case, remember we said no other confounding variables or no other reason for the symptoms. If you're convinced that somebody comes in with pre-existing anxiety, depression, comorbid conditions, pre-existing conditions of really not functioning well, that you can't see that much of a difference post-concussion, you could still go back and use that to say, I don't think this category then is valid, so I'm not going to use that category, okay? Or, kind of go from there. All right, so here's the example. You'll kind of see a little bit there. All right, so a 23-year-old scaffolding 20 feet in the air, lost his footing, hits his head on the ground, okay? 10 minutes of unconsciousness, regains consciousness en route to the hospital. He was confused. Glasgow coma score was 12. Somewhat unstable with balance, headaches and photophobia, CT, parietal skull fracture, and a small epidural hematoma. Kept overnight for observation, and then 24 hours of post-traumatic amnesia, so quite a bit. And then dizziness and photophobia, okay, over time. So he completes several months of cognitive therapy, improves, PT for balance coordination improves. Residual headaches a couple of times per month. Dizziness pretty much gone. No cognitive symptoms really to speak of. Declared MMI at 6 months, able to go back to full duty. Okay. So now he's using Cymbalta on a daily basis, but not really taking any kind of headache prophylaxis or abortive medications. Okay, so here's how the table would work. So the first thing you go through, so you categorize, okay, mechanism of injury, that was a grade 3, 20-foot fall, pretty significant, okay? All right, Glasgow Coma score, 12, okay, grade 3. Loss of consciousness, 10 minutes, I think we remember, right? Okay, so grade 3 there. Mental status abnormalities immediately, yeah, he did. Okay, post-traumatic amnesia, that was 24 hours, so that's grade 4, okay? So the next one, acute neurologic signs, not really. Okay. Physical symptoms, he did have some initially. Intracranial abnormalities, he did have a small epidural hematoma, right? Okay, so elevated blood biomarkers, nope, we don't really have that, so that doesn't get included in the calculation. Ongoing cognitive symptoms, not anymore. Okay, residual headaches, yeah, he has those a few days a month. Is he taking medications? Yeah, he is. And impact, no, he's back to full duty. So how you go through it is you just add up. So there were 4 of the categories that are this grade 1 or 0%. So 4 times 0, 0. You had 1 that was grade 2, so that's 5. Grade 3, there were 7 of those. So 7 times 9 is 63. And then there was 1 in the grade 4. So then you take the point totals and add them up and divide by the number of categories that you used as a denominator. So in this case, there were 13 categories because we didn't use biomarkers. So the total score divided by the number of categories that were utilized gives you a 6% whole person impairment rating. Okay?
So 20-foot fall for me is pretty severe. I think I would have given him a 14%
Could do.
of injury.
Could do.
So that is more on the subjective side.
Yeah.
And then like medication, is it like 1 medication is a grade 2, 2 medications is a grade 3?
Right. No, and that's where you can use your judgment to kind of figure out where you place that patient in. Okay. So this was just an example that had been thrown in. And so I'm just kind of reflecting what's there in the guides. Yes. Oh, yeah. I agree with you. 20-foot fall, significant. Yeah. Okay.
Really, otherwise.
Okay. So, yeah. Okay. All right. Hopefully a little bit more light there. Okay. A little bit of room to grow. This slide was actually taken up by Zermatt, by the Homestead. Just happened to catch some lighting right. So that was kind of cool. All right. Next, new section, rib fractures. So I had a guy that came to see me. He was about 60, construction superintendent, driving outside of Boise, gets hit by a semi. Part of his injuries, he had 4 or 5 flail ribs, kind of upper T-spine, and really had a lot of pain from them. How do you rate broken ribs? You don't, unless there's enough impact that it creates problems with pulmonary function tests. Okay, so the new section, there's 3 categories. Okay, so if they have rib fractures or non-displaced, no pneumothorax, no hemothorax, minimal or no residual symptoms, you don't rate for it. Somebody has rib fractures that are displaced, minimal hemothorax, pneumothorax kind of levels, moderate problems, some residual symptoms from that, 3%. And if there's multiple rib fractures, more significant chest trauma, open reduction internal fixation of the rib fractures, you can go up to 5. Okay, so that's a new section in this guide. And burns, okay? The last thing about burns, so I put in the old 2006 guides, and then I put in the new 2024 guides. So 2006, you would look at the total body surface area. If it was a partial thickness burn, that was the impairment rating would be the same as the body surface area. If it was a full thickness burn, you would double it. And then if they had extension into like the creases of the hands, the face, genital areas, then you would increase that by another, you would add another 10%, okay? Whoops. Okay, so you would add it. And then if they had disfigurement, you could add more depending on how severe the disfigurement is. So the categories are the same. It's just the rating that's changed. It was felt that these ratings were probably coming in too high. Okay, so how we do these now, if it's a partial thickness burn, the percentage would be half of the total body surface area of the affected area. If it's a full thickness burn, it's just whatever the total body surface area is, okay? If it's a deep burn that goes into the flexion creases, face, hands, or genital areas, now you're going to combine a 3% whole person impairment rating with that. And if there's disfigurement, you're going to combine either 5, 3, or 1%, depending on how severe the disfigurement is, okay? So let's go through, and interestingly enough, the example that was included is the same example that was used in the 2006 guides, okay? So we'll kind of compare that at the end. 42-year-old bilateral upper extremity burns and chest burns from a thermal fire. Right upper extremity was 5% total body surface area, including the palm. Left upper extremity, 3%, but it was partial thickness. Chest was 3% total body surface, full thickness. Okay, extensive therapy, now declared stable, painful right upper extremity contractures, and I think Dr. College used to throw those in just because he liked to get you thinking, if I have range of motion, where does that fit? What does that look like? How do you combine? So that's why that gets thrown in. Okay, so for the right upper extremity, he's got a 5% total body surface area. It's full thickness. Okay, that's 5%. Now he had extension into the palmar crease. Okay, combined with 3, 8% for the right upper extremity burns. Okay, left upper extremity was 3%, but it's partial thickness, so it's going to be half of that, 1.5. It'll round up to 2. All right, chest 3%, full thickness, that'll be 3%. So total impairment for the burns, 8 combined with 3 combined with 1.5, 12.5, that rounds to 13. Okay. Then we have the contractured right hand, decreased sensation that came magically with its own numbers, but we don't really have the measurements. So you combine those and that gives you 18% whole person for the range of motion, and the sensation loss combined with the 13% will give you a 29% whole person impairment rating. Now, the exact same example using the 2006 guide was 36. So you can see how it drops it down a little bit, not as much as you might think, but okay. Okay, for those of you not doing a lot of ratings or haven't started yet doing ratings, this reminds me because I like to play golf. I don't know why, but so, you know, you just got to get your hands in and kind of get a little bit there. So, okay. All right. Any questions?
I think it's, for me at least, worth discussion about traumatic brain injury, right? Because sometimes we see people come in and we diagnose them with concussion, and I know there's some ambiguity about that diagnosis versus traumatic brain injury. So how do you approach the person that's just hit their head at Walmart, right?
Okay.
I stood up.
So in the article that I showed you, they said concussion, mild traumatic brain injury, interchangeable. So you can use a diagnosis. And a lot of times, kind of, if I'm seeing them early on for treatment, I'm giving them prognosis that, you know, the vast majority of these are usually healed very quickly. In fact, so much so that they don't really do a lot of treatments initially because most of them are going to get better. Okay. Now, if it's somebody that fell 6 months ago and now they're seeing you for the impairment rating, then again, it's going to go back to, was there initial imaging? Did they have any documented loss of consciousness? Was there a documented loss of their Glasgow Coma score? Any of those things present initially? When they were seen initially, did anybody document signs or symptoms of more significant brain trauma? If not, and you have that documentation, every one of those is going to start being the 0 category, which is going to drop down and be kind of counterbalanced by whatever the level of their ongoing symptoms are. And if you're convinced that it's something else, that it's not really the symptom, but they've been coached by somebody or they have pre-existing stuff, you could always go back and say, I don't find this credible in this case. But even without it, you can still go back and say, okay, well, they're saying this is their level of symptoms. And remember, there weren't that many categories. So they did headaches, they did emotional lability, they had the impact of their cognitive, you know, are they working, are they not, kind of thing. And that's only 1 or 2 measures out of 14 total, or 13 if you don't have biomarkers.
Would you ever send somebody in that scenario, or at least suggest to the requester, right, the insurer, to consider like neuropsych testing, better ferret out some of those symptoms?
So interesting thing, because that was always my go-to until this year is if they don't have neuropsych, I don't want to try to evaluate an impairment because what am I going to do with that? And it was interesting in talking with some of the people, they say, well, it depends on which neuropsych they see.
Mhm.
You have some that are very much pro injured versus pro not. And so to be able to have something like that, it becomes more subjective. And so that's why, at least for now, it wasn't included in the overall mix. Yeah.
Back to that table. So if you were.
Which table?
The traumatic brain, yeah, that one. This,
Okay.
the 14. If you don't find them credible, where they're like emotional symptoms or something like that, would you throw that out? And so it would be
12.
12
Yeah.
instead of 13.
Yeah.
Okay. So
Or what you try to do is get some kind of other information, like, and it's hard because you don't know what to do if you can trust a spouse, but are they functioning in the workplace?
well, like no symptoms, but you find out that they're smoking a lot of pot to control their symptoms and
confounding variable.
right.
So I don't think I can trust that value. So I'm not including that in my rating. Okay.
You
And
can throw that out, and then your denominator would be
one less.
less.
Yeah.
Okay.
You have some verbiage that you recommend in your report for when you don't find them credible?
I think it depends on the situation. I mean, I really, in that case, you could just say, it's my understanding that there's some significant recreational drug use that may impact cognitive function. Therefore, I'm not comfortable including this in the impairment rating. But I went back and looked through the records. Here was the initial imaging. Here was their Glasgow Coma score. Here were their initial findings. And anything that you can use then gives you some kind of documentation to say, I'm looking to find, was there a significant initial trauma? And if there was a significant initial brain trauma, then they're probably going to end up with a little bit because there's more categories there. And then it tempers out some of those subjective long-term areas.
Possible to administer things like the test of memory malingering. So you don't have to send them to neuropsych. I don't know if you're advocating that, but I would, as a way to answer this question, because then you'd have some evidence. And we have that test up in the center.
What are you recommending?
TOMS, TOMM, test of memory malingering.
Ah,
There are malingering
Like
tools
scales.
out there, and you don't have to send them to neuropsych.
I see.
So if you got questions like that, that's a little bit more scientific way to try to get
Yeah,
it.
trying to put something to it. And again, the problem is that if you're here in this setting, you've got all those resources, that's awesome. And as you get further away, somebody, in Cedar City, not so much kind of a thing. So yeah, but you can see there's a little bit of work room. This is a framework. This is not, you can't paint outside these lines at all. This gives you a little bit of a framework, a little bit of meat that you can use to kind of help settle in and use it that way.
How do these apply to the date of injury? So are we going for injuries that we see that might be 6 years old, but now we're seeing them and we need to apply the ratings? Are we using the current the new guidelines, or were they the ones where they got injured, or those are more applicable?
So if you mean trying to determine if you're asked to do an impairment rating 6 years later?
Correct. So say they got injured in 2018.
Okay.
Now they're coming in to see us for the first time.
If they're, I would be surprised that they're being sent for a rating 6 years later, because
Well-
most of the industrial insurances wouldn't let it sit that long. But if you are, and so,
Well, for instance, the Labor Commission
Yeah.
sends us stuff.
okay.
Yeah.
That's kind of what I would try to do. You realize most of the cognitives, most of the subjective stuff is supposed to kind of minimize, but that's supposed to be over a few months. So I would probably still use the framework. But if you feel like there's been other intervening traumas or other things like that, then you may have to temper it a little bit further.
No,
It's
I'm just
hard.
saying, so we apply the 2024 guidelines now when we see a patient, even though the injury was in 2019.
Well, the idea, yeah. That's the current guides. That's all you really got. If you go back before that, you have the 5th edition, which is back to 0 to 14 or 1 to 14. So this at least gives you a little bit to say, okay, from the initial records, I can see they did this or this or this, and it gives you something. If you don't have any records, obviously, then a lot of those categories are gone too, and you don't have anything really to base it on.
Well, and I imagine if the judge is assigning it to a medical panel, they'll say, use the 2006 or the 2024 Utah Impairment Guides. They're not doing that right now. They're still recommending using the 2006, right? But if and when, they'll probably tell you which one to use if you get a case like that.
You're gonna switch to 2020.
I don't know. It sounded like they were waiting for something. Do you know?
There was a little bit of a discussion about, is it written into the statute
Okay.
kind of a thing, which my understanding is that that's not necessary, but they were still going to come back and rewrite. So it was a little bit kind of a soft thing there, but my understanding was that it's okay to go ahead and use them, even though there was a little bit of concern about that.
And probably depends on your setting or what, you know, who's asking you to do the IME, but at least for the Labor Commission, I guess we're.
Now, the other thing, if you're asked to do it using 2005 guides and you're using that first section, you have a 0 to 14% range, and you can determine wherever that goes, however you want.
Yeah.
So if you want to use something like that and then kind of eyeball where that puts you, and then just say, I think that'd be about 6. Okay,
0.2.
there you go. All right.
Thank you.
Yeah, and then the last thing up here, for those of you, if you have questions, concerns, I put a couple of email addresses, the one at Ogden Clinic. So interestingly enough, I didn't know this when I was named the Labor Commission Director, that the position used to be a part-time thing, I think, at some point. It's now kind of an hourly, little bit here, a little bit there. So I still have a full-time regular practice. So I'm with the Ogden Clinic. I do outpatient musculoskeletal medicine. I was just talking to a guy today, 50 years old, that had bilateral hips, just hip dysplasia, horrible. He thought he was having a back issue. He needed his hip replaced. But anyway, I came from there. So I just put in a couple of emails. The Ogden Clinic one is the one I see every day. The Utah Gov one, I'll check that a little less frequently, but we'll see that periodically. If you have questions, suggestions, options, concerns, whatever you want to, please feel free, reach out. I'm more than happy to have your input.
Carol.
Oh, go ahead.
Rehabilitation in medicine, when you said there's criteria for acute symptoms, if they don't meet those acute symptoms, they don't have a TBI, they don't have a mild TBI?
Now, again, I threw that whole thing in about the diagnosis because to kind of show where the current rating process came from. So they wouldn't qualify potentially for a diagnosis of mild traumatic brain injury, but clinically, if you feel like, yes, there was enough there, I could still go rate them using the 2024 guides. You can still do that. It's just they don't meet the strict criteria, but as you're going through that, it's going to pan out in how you rate them anyway. Yeah, I wanted to go more into depth in that article because it made so much more difference. If you're just coming across the 2024 guides and you see this 4-page table on how to rate brain injuries, and you're like, what in the world? What? And all this is acute? Why am I doing that? And it's not residual. And why? And if you understand kind of that process, you can understand, okay, we're trying to come up with a pathway that will lead us to consistency among multiple groups, multiple ages, and things like that eventually. And it's a step in the right direction from a 0 to 14, flip a coin, throw a dart. Okay. All right. Thank you.
Mention, if you're looking for CME, Bubba will send you an email with a link on how to claim your CME.
I sent it to most of you already. If you don't know who I am, probably didn't get with you so that I can agree on it. Exactly.
You may not remember. I remember.
For you?
No, specific.
You say that.
Come up.
Yeah.
I'm like, but Get it off. Awesome. I remember you walking out of the room, you're like, that was awesome. Working with that shit, man.
Yeah.
You were like, jangling your elbow, like pulling it, you're like, use this. And you're like, that was awesome. I was like, yeah, it was. Thanks for showing me. Like, I've never done that. That's great.
Oh,
thanks.
Yeah.
Resources, and it's like.
Yeah. First thing that would happen is she'd be in too much pain and.
Dr. Anderson?
Yeah, no, that's a good point.
Clinic, actually, it's just a radio practice. It was so helpful.
Yeah.
Great, thank you, Doug.
I usually do use Shepard.
Oh,
Yeah.
I am, so I'm the new medical director for the adjudication.
Welcome, I guess.
Yeah.
Oh my God.
It's really, honestly, feels like a nightmare. Yeah, I don't know if I'm.
And then he tells me kind of how his thing is. I mean, Alan is dirty. He and I were-
Doing a lot of cases.
Just, I mean, I initially came out, he was a Pioneer Valley. And then was still doing, he was with the railroad, he was their medical director. He was labor commission medical director.
I did, yeah, I noticed that too, so I emailed them and yeah, I think that's the best. Yeah.
For a while.
I don't.
He told me, then I thought to them,
Yeah, it's great. All the awareness.
So what,
I think it's.
what exactly is your director of what? Industrial accident, okay.
So basically, kind of what I was doing, so.
I couldn't find it again, or maybe it's not in here and I.
We're having a meeting.
Program.
Although we can make recommendations to the advisory committee, so that they can decide whether
So
to change. it
more
first.
administrative,
Something like
workers'
that,
comp
yeah.
stuff, whereas we're doing
Regular
just medical.
stuff.
Got it, got it. All right.
So, yeah, and I actually, we had reached out to them, tried to get them.
Like, oh, this was already like an. I want to read it.
One is that primarily would be like emails that come in.
If I had been, I would have wanted to be a part of it, but you know, you guys did the job and it seems like it's great.
Well, and this.
Oh my gosh, I
this
didn't know
part of
worry.
it
But there's a whole line in there, yeah.
Evolution,
Yeah,
kickback,
so
and
I'll-
all the rules.
I responded to Jake.
And
There's
it-
some great
and it-
things.
it was
Well,
when
Yeah, I get it.
Alan came out. 2006. First time they came out.
Sent you some emails.
What, three, mild, minimal, what? And then, it's like,
Yeah.
Are you just having trouble hiring?
I,
Yeah.
now it's, you have to have a subscription.
Contract,
you know, all the
finished so
time,
late.
so
Just came out with the seventh one, right?
I didn't see that. I haven't looked like it.
I think it just did, but,
Yeah. I know it's on there. Yeah, so they're just rewriting it.